Thank you for turning up again. This week we're talking about midfoot arthritis. Very common, very common problem. I presume there's a number of podiatrists here. You all know about the foot biomechanics. The midfoot is really a very important area because it's an area which is under a constant load transfer every time we take a step through a very short distance. And it's a relatively rigid area of the foot, but it's vital that we get that this is working, get the correct movements we want. In that area, there is an element of dorsiflexion and plantar flexion in its own right, but it's very limited. As I say, it's a fairly rigid region. You've got 4 to 8 degrees dorsiflexion in that region. You've got 10 to 15 degrees plantar flexion. So it is very small, but that all contributes to the eventual movement that we have in the foot. So we'll come on to this and the real causes that we have. But let me just first of all go through the ACER slides. Right, midfoot arthritis treatment with MLS. The multi-wave lock system, just fantastic little adjunct to have. As I've always explained, in every webinar we've done, no machine is the answer to everything. It's using your brain, it's using your skills, your clinician skills, put it all together, and then having this fantastic tool which can actually do wonderful things, particularly in reducing inflammation, which we'll have in a midfoot arthritis, but also it has some reparative aspects for the collagen. The only problem is getting into that area because, as I say, it's a fairly rigid region. So when we look for the optical window to try and open up, not the easiest thing in the world. However, having said that, we'll go through also some causes of this, but things not to miss. Let's go on to the next page. Here's a nice little fellow walking. That midfoot is working all the time. Okay, right. Focus on osteoarthritis. Why MLS laser therapy? Just let's go to here. Studies have shown that laser can decrease the degenerative process, i.e. slow down the osteoarthritic changes which are happening in the body, decrease the prostaglandin level. Again, in a real itis situation, there'll be tons of prostaglandins, which the inflammatory proteins, reducing the inflammation. What I did want to point out was, sometimes we talk about midfoot arthritis. I'm just really wondering, I don't know what the general world opinion is at the moment, but in things like this, I would have thought it's more like a midfoot osteoarthrosis, because we have degeneration from the mechanical problems which are happening in the foot, and we have a load of degeneration. There will still be a hell of a lot of inflammation in there, but reduced from pain will also be coming from other aspects, just with the degeneration within that area. So arthrosis is something which we should probably consider calling these things. Right, increased protein level with repairing effect. We can actually start the regeneration of the cartilage. We are not, understand this, we are not going to give you the foot back of an 18-year-old person, but we can start repairing the cartilage because it acts on the chondrocyte activity, and then we can start repairing some of the cartilage. What is very important to understand is it's not going to make you 100% better, but by increasing the chondrocyte activity, you're getting some reparative effect. At the same time, you're stopping this getting any worse, and this is the big problem. You'll improve the cartilage thickness. Again, there is no nociceptors, no pain receptors in that arctic cartilage. It's shiny, hard stuff. Probably in that area of the foot, in the foot, it's probably only 2 millimeters, where it's actually much thicker in the bigger joints in the knees. But the load which is going through that foot is just enormous. So we're hampered slightly by this. But the big thing that this laser is going to do is reduce pain. And as I've said in every webinar we have, pain is our big enemy. Pain stops people moving. Pain puts people into avoidance. Pain puts people into a spiral downhill. We need to get some movement on these joints. We've got to get that midfoot moving. We've got to get some reparative aspects going on, yes, with the laser, but also just by getting a bit of blood supply and a bit of synovial fluid through there. MLS laser advantages and benefits. It's a conservative treatment to postpone, they put down here, implant surgery. You're not going to have an implant. Well, you can have an ankle implant, but just in that midfoot, you don't. The surgery they're going to do, which we want to avoid at all costs, is basically a fusion of that whole mid-tarsal area. Offers a faster, more effective action on pain, edema, inflammation. That's the important thing. We're going to get the pain down. We're going to get the edema down. We're going to get the inflammation down. Stimulates reparative and regenerative action without causing micro damage or trauma. Also using it, which is we're not talking about today, but post-surgical, immediately after the operation to reduce edema, increase microcirculation, and rapid reduction of pain. Minimize the post-operative fibrotic scar tissue formation, but it will also heal that scar. If you've had the one I always think about is the scarf osteotomy, because I've seen a few of those. It will get that scar healed up in half the time, just by using the biostimulation aspect, which means we can get working on these people much quicker, which is great. Reduces inflammation, swelling, and bruising due to injury or surgery. It speeds up your rehabilitation plan. So, as an adjunct, it's a phenomenal piece of equipment to have. It's not going to replace the stuff which we need to do, but it's going to help you, and it's going to help you with your clinical outcomes, because they're going to be improved so much just by using this in conjunction with your own skills. Settings for osteoarthritis: very acute, low frequency intensity. I don't think we're ever going to come down to this very low intensity, low frequency stuff, because as I said, this is generally what I would term an osteoarthrosis. We've got degenerating. This is chronic. Subacute equally. Medium frequency and intensity, 200 to 400 hertz, intensity 50%. This is just very rough guidelines. Just always keep this in mind for other stuff you're doing. But the chronic, which this is mostly going to be, is high frequency or CPW, an intensity 1,000 to 2,000 hertz, or the CPW, which is the continuous. Right now, in most of the sessions we've done, I've talked about the CPW, and I said stay clear of it just for fear of a rebound effect, because we'll see later we will be actually increasing the power gain to there in terms of joules into the area massively. Not good in an acute situation or subacute, because you're very likely to get a rebound effect where you'll get some increased pain afterwards for 24, 48 hours, but then it will ease down. And that's the body rejecting the amount of power you're putting in here. However, if you've got this very chronic situation, and I use this on knee arthrosis as well, I actually do often use the CPW. I might not the very first time, but if I'm not getting the changes I want straight away, I'll get straight into the CPW. It will all become clear, those who don't know what I'm talking about. Okay? Right, global approach. What we want to do, the global approach, always remember, if you've got your little booklet, it talks about area mode, it talks about pathology mode. If you've just got the handpiece, that's what we want to do. We want to do the scan of all the surrounding tissues first, and then we want to go in on the pathology itself and do a different setting for that. So we want to get the photobiomodulation going into all the surrounding tissues which supply the area, increase vascularity, increase reduction of inflammation, reparative, increasing ATP in all the cells. We want to do that to actually really get a massive start, and then we're going to go on to the pathology setting. So that is basically it. Hopefully that made some sense to you. As I told you, when we get the patient, there's a number of things which can cause midfoot pain. And the obvious one is what we would think of as the midfoot arthritis or arthrosis. But always remember, other things that can be a problem is just check past medical history. Do they have a neuropathy? Do they have diabetes? Is there an inflammatory disease involved in this? Now, by an inflammatory disease, obviously rheumatoid arthritis is a really nasty inflammatory disease, but they might have no HLA-B27 markers, no rheumatoid factors in the blood test, but they might still have something like psoriatic arthritis, which is, to all intents and purposes, it's rheumatoid arthritis. The immune system has gone crazy and the joints are eating themselves. And this is incredibly bad. So we need to know further. We've got to work out. Always question very carefully with the patient, especially with something like psoriatic arthritis. They might have really no psoriasis plaques over them. They might have a tiny bit in the head or something like that. But look out for an enthesopy, real problems on the major joints, tendons. It's usually unilateral. Look for a dactylitis, a sausage finger or a sausage toe. These are little signs. And check their nails. Pitting in the nails is a big sign. The reason I know a little bit about this is I had a patient with real bad midfoot pain, and I told you to check for other things, okay? I suspected, because they jumped off a high wall and they had midfoot pain, and I suspected a Liz Frank injury, not to be missed ever. And if you're in doubt, just go and send down to the hospital for an X-ray to check if there's a Liz Frank injury. There will be widening in that tarsometatarsal area, especially I think between the second and third. But anyway, look for that. But the X-rays came back fine, and then we did further investigations. And we discovered that they had psoriatic arthritis. Now, we can't diagnose that. That has to go to the rheumatologist. But that was just a massive problem causing the midfoot pain. Unfortunately, the person is on all sorts of strong drugs, methotrexate, sulfasalazine, and now they're on some biologics. But that is controlling the pain in the foot. So it's not an arthritis situation. However, they're liable to get some problems later on if this isn't controlled well. Check for the history of trauma, as I said. Have they jumped off a wall? Look for the Liz Frank injury. Liz Frank injury, it's called Liz Frank because it's named after the French Napoleonic surgeon. He used to deal with it. And the way he used to deal with it was amputate the foot at the tarsometatarsal line. And that's how you sorted that out. We don't want any Liz Frank surgery. Right, so evaluation is very important. Is it post-traumatic? Is it idiopathic? Is it from an inflammatory disorder? The other thing is deformity in the foot. Now, when I'm talking about deformity, I'm not talking about some big, second head popping out of your foot or something. When we talk about flat feet or very high arches, can be big areas, because that whole area, that this tarsal area, midfoot area, is relatively rigid. Now, there is a little test we'll show you afterwards how to check if the foot is locking or unlocking. But certainly in calcaneus neutral slight eversion, this will move really quite massively. You'll see it's different. When we come into inversion, it should lock it slightly. And if it does, we know that we've got fairly good locking of that midfoot. You'll get some people where you bring them into inversion, and then you start moving this, and it's still flying all over the place. They have a problem coming up because when they're loading this all the time, this whole area is moving massively, at different times, different sorts of pain all the time, and we get problems. Equally, a low foot arch, you're more likely to get the collapsing in, navicular drop, stuff like that. I do have a little foot here, and you can probably see on this, here we've got the tarsal, tarsus, and here we have the navicular, and you can see it's opened up and there's a big drop in there. Very common in a flat foot. In a high arch foot, we're really compressing it together. This becomes over rigid. There has to be some movement in there, and the high arch foot is just all crammed together with a huge pressure then coming through in mid stance and then the toe off. So that is a bit about the biomechanics. Always check their feet. See if the windlass mechanism is working. Check for ruptures. Is there any activity there? Are they getting this inversion and arching of the foot when you bring the hallux up? If not, then they've probably got more of a collapsing foot going on, and there could be a sign of eventual midfoot arthritis. What do we do about it? Well, the usual things, you know, your activity modification, try and reduce the impact from this area. Big area is weight loss. Tell people to lose a few pounds, skip a few meals. It might seem a bit rude, but for every pound you lose, you're losing 5 pounds of pressure, which is then coming through this foot on your walking, on your gait. So it's always worth knowing that. They can always take some anti-inflammatories. You'll get the surgeons, the osteopaths, and all the some GPs will say, look, let's inject it with a steroid. Just don't do that. There's ways around this. Steroids, it will reduce the inflammation in that area, but it will stop any healing process. And we certainly can't just use the laser straight away after they put the steroid in. It's just going to have no effect. So try and avoid the corticosteroids as much as possible. And finally, obviously, shoe modification. Now, I talked about a couple of times ago about shoes. It's so important. The easiest test in the world. What you need is, a lot of people use these rocker style shoes, which helps with the midfoot, so it keeps it more stability. But do you know what? The most important thing of all is an arch support in there. So it's got some control. The foot is going over something which is controlled. It's not giving way, and that's happening, okay? So when you get your shoes, I'll just do it again. Get your shoes. Now I'm going to show you with my Crocs, which you would probably think are the worst short shoes possibly in the world. Have you got any other shoes? Can I have your shoes? Let me get my model here, and let's see how bad her shoes are. Okay, right, here's my model shoes. My feet aren't that small. I'm going to push these in. I hope these are bad. Right, I'm going to push them in from end to end, and actually, they're not too bad. They're going a little bit further up, but they're probably had a few too many miles on them. But they should be going at the MTP joint. This is where it should bend. You'll get so many shoes. I'm going to force this, which are these actually not too bad at all, which will go at the MTP joint, which means the foot is just going to drop down, and it's a danger for you to wear it. Now, here, whenever you get your shoes, do it. Crocs, okay? Look at this. Crocs, you think these are going to go right in the middle. I'm going to push them right in. Bang, look at that, eh? Fantastic. MTP, get yourself some Crocs. Very comfortable and supported in the arch. So that is probably the most intense recommendation I can give you. Okay, right, let's move on. As I said, beware of a midfoot sprain or a Liz Frank injury. We don't want that, because that will cause some real problems getting better. Let's go straight into actually checking out settings and how we're going to apply the laser to this foot. Just let's go over very quickly. How's the laser working? it's sending 2 widths of light, all in that therapeutic window where we can get the depth up to 6 centimeters, 5-6 centimeters, which is really between about 780 nanometers and 950 nanometers. It's a very small area in that infrared spectrum, which allows the depth, because what's happening is that width, it's allowing the laser light to hit not just the watery tissues on the surface, but the hemoglobin, the melanin, all the different things that we need to work on. What's it doing? Sending 2 widths of light. The 808 nanometers is sent in continuously, and I've done that because we're going to discuss the CPW thing later. But it's actually not completely continuous, it's chopped. So it comes on and off. That's all relating to the hertz. You'll see the hertz on the system here. That works, what it does, it starts a protein synthesis. It infiltrates the cells with ATP, which oxygenates the mitochondria of the cells. Starts a natural repair process. They start activating, they start working properly. Bit like injecting yourself with EPO if you're with Lance Armstrong, but nothing illegal. It's doing that. At the same time, it's actually activating all the anti-inflammatory proteins to bind onto the ATP. So you get a huge reduction in inflammation. At the same time, especially if we have the hertz really high, or we have a continuous, we're actually increasing the mechanical effect. We're actually causing a bit of, more vasodilation. We're causing more active heat, and it will actually move the blood through the area. So we're getting a much bigger mechanical effect as well. That's having at 808 nanometers. So we're reducing edema and inflammation, 2 things which will also cause a bit of pain. You've got the 905 nanometers. What's that doing? That's sending in light at 25 watts, massive power. Some of these machines even send it at 75 watts. That should cook you straight away. It won't cook you because it's all super pulse. So the tissues come on, the light comes on, off, a nanosecond each, very strictly pulse. Nanosecond on, nanosecond off, nanosecond on, nanosecond off. What happens is the tissues heat, cool, heat, cool. You get all the thermal effects that we want without any of the thermal damage. The 905 nanometers width primarily works on blocking, inhibiting the pain pathways. So we're getting this huge amount of power, which is blocking pain pathways. At the same time, we're getting the tissue repair, and we're getting the reduction of inflammation, and we're getting the reduction of edema, both things which cause pain, all happening at exactly the same time because they're synchronized together, multi-wave lock system. So you get the synergy of effects with all 3 things working together, phenomenal results. Okay, no need to say any more about that. Are there any questions flying in about what's happening there, or is it all okay? Yeah, I'll continue. Okay, right, that's what's happening. Let's get on with messing around with this midfoot. Midfoot, a very small area, as we showed you. Here we have the navicular. We've got the cuneiforms. We've got the cuneiforms here, and then you've got the cuboid. This is so important in gait. This is an area which has to move. All sort of irregular shapes, but they have to work together in a very good manner. If they're not, and you're getting too much pressure on something else, then you're liable to get some damage on the articular cartilage, and this is where the problems all start. So let's actually, I'll tell you what, let's just, before we get onto the computer, let me just show you that little movement. Can we get the patient up on here? I'm just going to show you this little thing, just checking the midfoot, if it's locking or not. Very simple. Here we have our patient, the lovely Francis. The lovely Francis is not dressed up in PPE, neither am I, because the lovely Francis is my wife. So therefore, we're okay. It's an incredibly simple little test. Okay, bring the foot in. Okay, so just relax. Really, but no, just relax. Okay, now you'll see it's actually, if I bring this right in, we move here, but in the midfoot, it's actually pretty good. If I bring it out here, look, we've got loads of movement. So I know that she's got a fairly good locking system. So through the gates, we should not be getting too many problems in here. There can be all sorts of other problems which can occur, but it's always a nice thing to know. Okay, locks. Can you see? Can you see? We're moving here, but we're really looking quite well there. When we bring it out here, we've got really quite a lot of movement. Okay, so just remember that. Really lock it in there. Inversion and bring it out. Boom. Movement there. Locks. Okay. What you'd see is you'd see this massive movement there on the there if she didn't lock, and that is always a sign to look for on the foot. Right, I'm going to go back to now to setting up this laser. Right, this is the screen that will come up for all of you. Well, no, sorry, wrong, not for all of you, because if you haven't got the Charlie head, you will not see this little thing here. What happens is when you plug the Charlie head in, this appears and you can just press on that and you can set the Charlie head and you can set the two things completely separately for doing different pathologies or different actions. We can do the scan with the Charlie head or the handpiece and do the pathology with whichever one we want, depending on what we set, okay? But we don't have that. We just got...
Actually, I had a question about that, Paul.
Yeah, yeah.
So the Charlie head has the same opportunity to treat the same pathologies, doesn't it? But you can't use it for a scan as such. So you would use the handpiece for the scan.
The reason is it's covering a much bigger area. So you don't need to scan it. It's covering all the area. What you'll always see on there, there's actually slightly higher joules on the settings for the same pathology on the Charlie. But on the Charlie head, that is set at, I can never remember, is it 15 centimeters or 20? It's basically, it's
20, I believe.
Is it 20? Okay, it's my finger, I'll show you. It's about 6 inches, okay? And that's 6, 7 inches. That's the difference. I just mark where it is. But it sends more joules in because it's from a distance and therefore some of that will be dissipated. So what reaches the skin and goes into the tissues will be the same. Okay, does that make sense?
It does. I'll allow people to ask in. Right. I'll jump in if need to.
What we're going to do is we're going to go straight onto the foot, okay, because we've got midfoot arthritis. And people say, right, foot arthritis, let's get straight in there. No. What we're going to do first is global approach, okay? We're going to scan all the tissues involved in this. So what I'm going to do is I'm going to go onto the scan first, okay? And it'll come up acute, but as we've already discussed, this arthritis thing is generally going to be a chronic situation. It'll come here 4 minutes at 500 hertz. You can see if I'm acute, it's 300 hertz. The hertz are up a little bit. 500 hertz, 4 minutes, 75%. I really would not be too worried about in an acute arthritis doctor scan, even just going to 100%. It's going to change the amount of joules. It doesn't give you joules per square centimeter because we're scanning. But if you look here, that's what it was. It was 103 joules total that's going in. We've got 136 joules. And when we're talking about the CPW, which I probably wouldn't use on the scan, but we double that up massively. I'll explain later. Okay. So let's go press back on there. We decided to go up to 100%. Okay, I'm quite happy to do that. And what I do is I press start. Okay, what I do is I now, it's not going until I press the button on it. I'm going to get the change the screen, but make sure you stick your glasses on because this is infrared light. You will see a red area where it's showing you where it's going, but that is an LED. Infrared light you cannot see. It will bounce off anything that's metallic, and if it goes into your eye, it will cause you retinal damage. So don't take this lightly. Use the glasses. And she's got bad arthritis in the left foot. Because what I'm going to do is I'm going to get her to bend this knee up here, so I can actually get in all these areas on the back as well. Just looking at it, I'm going to get down here, cross here, right through here. Right, what we do is we literally just start it, okay? And I can't. Can you see this is on? Actually, let me just stop it. I'll turn the lights off. This should make a nice picture. What we do is we're going to get in here. So you're thinking, what the hell is he doing up on the leg here? I'm just doing a bit on the. Can you see this going here? I'm just doing all the gastrocnemius. I'll move it around, all around here. Blah blah blah. Right now, on this thing, really have a good go on the tibant as well on this, because this is a big area which it joins to some of those mid-tarsal bones. Get on there. Let's come right over here, and then we can actually go right over the foot, just scanning all around this area. And I can't remember how many minutes it said, but I'm not going to go on the full time. But we're doing all this over the foot. I'm going a little bit quicker than I probably should, because we're saying this is a fairly chronic situation. And in the chronic, we tend to scan a little bit slower. So right up here, and it'll keep on going until it's finished, okay? And then it'll just go, I'll tell you the noise it will make, because I'll stop it here. And you probably heard it like that, and it just stops it. Right, that is the scan. What we're going to do is we're going to go on to the pathology. So, right, I think we're going to have to come back for a bit of education in a minute, because what I'm going to do is, this is a very chronic situation. And I've got no problems really in an arthritis like this of using my CPW. But let's try and explain a bit first. Okay, what we're going to do now is we've just finished the scan. Okay. What we're going to do is we're going to go on foot arthritis. Now, you'll see here, don't follow this. This is just a guideline of all the joints where you can actually apply this. We know what we're going to do this over. We're going to do it on all those mid-foot areas, and we'll still keep it at 15 points, okay? It's saying it's 500 hertz. It's saying 5 minutes. It's saying 50% at 15 points. I'm saying this is very chronic. This is pretty nasty stuff. So I'm definitely going to go up here. Now look here, actually, let me go back. You'll probably see it's 1.87 joules at the moment, they're saying. I'm going to go up to 75%. It's now 2.74 joules per square centimetre. It's giving you joules per square centimetre because it knows exactly what, it knows that this is stopped on an area while we're doing this for 15 points, okay? So each particular area will get that per square centimetre. We go up to 100, we're putting 3.62 joules in there. Right, now, this is fairly low compared to some things you'll do, but I'm going to actually go on to the CPW. It's 3.62 joules per square centimetre. If I press that, it goes up to 7.46. How has that jumped up? Well, if you notice, when I press that CPW, this frequency disappeared, okay? And what goes in there is a little CPW. Right, now, let me just come back and explain this if I can. Right. Okay. I've done a lovely bit of drawing here, which hopefully will help you. I told you there's two widths of light which are going into this, through this laser head. There is a continuous wave, but I did that, didn't I? Inverted commas. There's a continuous wave, and then there's the pulse 905. 808 continuous, 905, 25 watts, super pulse. Right, let's have a look at it. Then if you look here, what's happening is on the 808 nanometers, on the frequenced pulse wave, it's what it says, it's frequency, okay? So it's off, it comes on, and it goes on and on and on, and it's off. And it goes off, and it's back on, and it goes off, and so on, depending on what frequency was set, okay? It can be higher, lower, whatever. But there is an element where it's off and it's on. What's happening is, it's all synchronized. Once you got this, you got the 905 nanometers at 25 watts. This is 1.1 watts. This is 25 watts. What's happening then? Every time this is on, you got ding, 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 right through this, nanosecond, loads of them. When we're talking about hertz, say 2000 hertz, that is nothing compared to nanoseconds. So one is really, truly super pulse, and one is basically continuous. But you got this on, like mad, off, bang, 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 on, okay, on, bang, 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 on, okay, off, back, on, going like crazy. Okay, what happens is when we press the CPW, it actually removes the hertz. We have this no longer any element of hertz, and it is just a continuous light going through there at 1.1 watts, and then this is going through continuous as well. So you automatically just double up the joules which are going into the tissues straight away. And it's a fantastic tool to have in something very stubborn or very, very chronic. It's not a tool which should be used by, you know, your average bloke who thinks more power is better, and the person comes in with a very acute problem, and he starts whacking the CPW up there. They're going to ring up and say, oh, it's got slightly worse. And all you have to do is say, look, it'll be back to where it was in 48 hours. It was just the idiot physio who did that. We'll make sure he knows, okay? So, but in this situation, very chronic, use it, okay? On really bad, you know, degenerative knee arthritis, use it, because we want to get as much power in there as possible. The other thing which I want to say just before I go on here is two things. Well, two things I want to say. One is we want to try and get movement when we're doing this, laser treatment. But probably not the very first time I do it. Movement, because you get all the tissues around there will start activating. But the other thing is, in a real joint situation, you sometimes really don't do the movement as much, because what you've got to do is you've got to look for the optical window. Now, what I'm talking about the optical window, the biggest problem on the foot here is going to be on the dorsal aspect of the foot. This is where the problem generally is. And we want to get into these joints. It's a fairly rigid area, this. It doesn't move very well. But to move it in any way, if we do that, then we're actually getting in there. You probably see that's just opening up a little bit. All I'm doing there is I'm actually just trying to bring the foot down a bit, okay? So if you get them to try and dorsiflex when we're doing this actively, then we will actually be opening this up a bit, and then we can get the light in these areas, okay? If we don't, we're going to, yes, the light will be going on the edges, but we want to try and get it in there. And the more we can actually just open up, look for the optical window, then the more we'll get the light in there, and we have a bit of movement. We can also get them to just invert and evert a little bit. So by inversion, dorsiflexion, inversion will probably be the best thing we can do, and actually just to work on here. Okay, hopefully that makes some sense. So what I'm going to do is I'm going to get straight back to my patient. What time is it? We'll just do the treatment on here. I'll just show you quickly how we can do something with the Charlie head as well. But on this midfoot stuff, I tell you what, you use the Charlie head, you can go and have a cup of tea and come back in 5 minutes and it's all done. But let me just get back onto this other bit. So we're back with the patient. Let me just check my settings. I did the foot arthritis. What I have done as well is I put the CPW on here. So I'm chucking in high power, okay? And very simple. Which was the foot we were treating? Okay, we're treating that one, okay? We're coming in all this area around here, okay? What I said was try and get them to put the foot down and bring it in a bit, okay? And just by doing this, I'm opening up these joints, which I wouldn't have done. If it's up there like that, we'll probably all close. Let's just try and get the optical window as much as we can. Get it like that. Let's move that around there so you can see roughly what's happening. And we're going to go, we found, oh, sore, okay, all these areas. Okay, you get on there. Can you see this is working on there? Okay, there's 15 points. So actually, 15 points for how long, how many minutes was it? 6 minutes? It should stop in about 30 seconds. I don't have to do anything. I just leave it there. Stops. And I'm going to move into the next bit here. Okay. And I'll just go around all these areas and I will do the arthritis on here. As I said, I've got this on the high power. I will call her the next day and say, how is it? She'll say to me, do you know what? Actually, I'm feeling so much improved. Or she'll say, no, it's actually slightly worse. And I'll say, well, hang on. You said you had this a long time. No, it's just happened this week, okay? And then I know I've been an idiot because it's an acute situation. I put the very high power in there, okay? So literally, it just stops itself. We go to the next bit, next joint. We're going to go in here, feel all these areas. And so on. Let me just show you exactly what's happening on the laser itself. Going to keep that running. Oh, it stopped again. Okay, let's start again. Oh, can you press the button on there? Right. Yeah, good. Yeah, you get the patient. Do you know what? Actually, patients often like doing this themselves, and give them some part of their treatment. They honestly they love doing this. They get very much into it. And again. Okay, right, now you can see what's happening. It's down to 10 points. It's counting up the joules. We know that each point is going to have 7.46 joules per square centimetre. It's counting down the time, and you'll see it'll just stop itself, and that will go to 9 at the next one. Okay, gone to 9, it stops, and she starts again, gets going again. And that will go to 8, and so on, until it's all finished. Okay? I'm going to stop it there. So we can see foot arthritis. It's literally 5 minutes. Plus I did my scan, which is 4 minutes. That's 9 minutes of treatment. And I'm giving them a treatment which they will find unbelievable. Yeah, you can do these things so quickly. On a midfoot arthritis, which is really crippling them because they are not able to walk. Make sure you get them the right rocker shoes or something with a good arch. Make sure they're probably taking some anti-inflammatories. Use a bit of ice on there, but give them the laser, and this will just change things forever. And they'll start telling everybody how great you are. That is basically it as far as I'm going to show you with the handpiece. Let me just very quickly show you how simple it is using the Charlie head. So I'll just come back here. If you've got the Charlie head, this is. If I get back on there. Okay. Right. We're on here. Charlie head, what are we going to do? Okay, let's stop that completely. Okay, going to go to the Charlie head. I'm going to go on here. Foot arthritis. You'll see the jewels are much higher here when we start doing this. But let's say this is pretty big stuff. Okay, this when you're on the Charlie head, it won't go to 75%. We'll just go straight to 100%, and let's put that in. Now, I actually think that might be just a little bit too much. I'll probably leave that back down to 50%, but now we're up to 15 joules per square centimetre, okay? I'm using the CPW in there. What I will do, actually, I'm going to start that. It won't start going until I press the button on the thing. You'll see in a minute. But what I'm going to do is, at the same time, I'm going to treat her neck pain, okay? So she's sat there, I can get into the, yeah, I'm going to treat the neck pain at the same time. Muscle contraction, let's go on there. 5 points, blah, blah, blah. Start that, it's fairly acute there. Right, get your glasses on. Change the thing over here. That one. Okay, right, now, same old thing. Could I get you to, I'll bring the chair head down here. How far should it be away? It should be that far away, okay? So having the metal, you've got a metal thing which sticks in, which I don't like, okay? I'm going to put it over the midfoot there. Remember what I said? Optical window. Let's keep that there. Let's get that round there. Okay. And let's start that. Okay, I'll press the button there. So, beautiful. Now, what it'll do is it has 2 points, so I'll just move it here and just move it a bit further down. Right, I can now go and have my cup of tea, or I've already set this up. I can go and treat her neck. So if I just press that, then I start treating the neck. Completely different settings now, different pathology. I think what I will do is, I don't think I'll treat her neck. I think I'll go and have my cup of tea. Okay? Whatever. Anyway, so that's the situation there. I'm going to let that continue.
Just quickly on the mobilisation, because that has come up a couple of times in conversation to me in the last week or so with customers. So the mobilisation, obviously, we know the benefits of mobilisation whilst treating, but is that, so you touched on it there, I believe, a bit. You're also getting then the
I'm very
about the optical window at the same time. Is that specific to the laser?
What we would do is, if it's any structure which is more a where the joint can, let's say in the back, so we can get the facet joints moving and stuff like that, we'd probably do that. Where when we come down, let's say doing Mackenzie, it'll open up and then close it a bit, but we're getting the a bit of light through there as it's actually gliding on those areas. You're really going to use the mobilization much more if you're using structures which are either muscular or tendinous, collagenous. And that's where you want to get these collagenous tissues as they're working. This is where you want to get the photobiomodulation on them, as opposed to just static. Often, the very first time you treat them, they might be a bit sore. So then just static. But as soon as you can, certainly probably try it the second treatment. Start trying to get them to move these things. So on any collagenous, any muscular structures, get the movement while we're doing the treatment. What we're looking at when we're looking at a joint, always look for the optical window. There is a bit of an overlap, as I said, about that back area, because it never harms to get a bit of movement in there at the same time. But on a joint, on a shoulder, on a knee, on an ankle, optical windows, we want to get in there because this laser will not go through the bone, but if we open up the bone and we open up the joint, it'll go right in there and have the effects, okay? On the collagenous muscular structures, we want to get this as it's working, as it's active, and we can get some the photobiomodulation on there and get the improvements as we're working the tissues.